Good evening, everyone. I think my audio works. Looks like it. Dancing P, first one in the stream. Welcome, welcome. Thanks for saying that. Matheson. Ooh, good question for everybody is how would you determine if POTS is caused by a neck injury or vestibular issue if they're all present? We're going to get to that. Cool. Katie, what's happening? Nice to see you guys for a little Thursday evening chat. Hello, Irene. Good to see everyone. And we're going to get going. So last week, for those of you that were here, we were talking about how we diagnose POTS, like just super simple. And then I added in some of the components of like how you go deeper and understand it a little bit. So we're going to do some more of that. We're going to go through it. And then we're going to talk in those bullets. I'm going to try to like zone in and just do that part and give you the concept. And then we'll talk about we'll take questions and kind of get that stuff done after that. But I think I'm finding that if I just try to jump back and forth, I end up getting just kind of lost in it and it becomes not very cohesive. So if that's cool with you, that's the way I'm going to do it. Megan, let's party. Nothing like a pot party. Corey Black, good to see you, my friend. Peace, love, Mung Bean. Hello. Do you only treat people with POTS? That is not actually how I started in the world. It just has it's where life has evolved. No, we don't treat people just with POTS or even just autonomic disorders at large. A lot of what we started doing started with concussion. There was just such an onslaught of people that were dealing with POTS that honestly was just kind of like forced to figure out as a consequence of that. And then more and more and more, and that's how it goes. So yeah, that's not the only group, but as a structure of the way we think about things, it's a group that, as you can see, there's a lot of room to help. So that's the word. Okay, everybody. So let's do this. Here's going to be our structure today. I'm just going to go through, kind of burn through a little summary of what we did last week, talk about the last few endpoints, summarize that, and then we'll do some questions after that. Cool? Let's rock and roll. So I'm going to let them accumulate in the chat. Sometimes people get a little impatient or like, answer my question. I got you. Just let me do this part. And then I'll go through questions after that. If you want to load them in, that's fine. Just be patient if I haven't gotten to them yet. Cool. Nomad over normal. Welcome, welcome. Good to see you. Glad you made it. Been a great day today. Had a great time in the clinic today. Just a fun day. Good folks, just having fun, a lot of smiles. And so I'm happy to be here. Let's do it. All right, let me set this up. Whoa. So I'm using a new camera. I thought I turned this feature off where it chases me around the room. I guess I did not. So that's fun. And off we go. Okay, let's pull this up. Let's share the window. Bam. Looks like that's where we're at. Okay, so this is where we started. It's just like, if you're new to the game, starting to have symptoms, what the heck is going on with me? What do I do? How do we go? That's where we're at. I'm going to pull this up with my iPad so I can control it. And there we go. I think. I might have to stop sharing and restart that. There we go. And I'll put me in the corner here just for fun so you can tell I'm still here. Hey. All right, let's do this. So how do we do it? 4 steps, super basic. This is out of the consensus statement. It's not me making it up. But this is just the general structure that you can think about it with. So before we get anywhere, we have to decide, is it something else? And that's the obvious question. And here's a list. We went through it last week. Hey, Dr. Purcell, good to see you. Glad to have you here. So we went through this last week. If you just want a list like this, and this isn't everything, but it gives you a good sense of like definitely places to start. If you're just starting on this journey, like these are the things to definitely start by ruling out. Take a little screenshot if you want to remember it. I went through them last week. We're going to skip through that. But number 1 is it can't be something else. So if it's something else, it's something else. Okay. And then we don't have to worry about, understanding the tachycardia part, because the tachycardia is going to be secondary or as a consequence of one of these other things. Cool? Cool. And then number 2 is we want to make sure that it's chronic. And by chronic, we mean chronic in terms that it's lasting, it's persistent all the time. And by that chronicity, we typically mean it's going to be at least 3 months. Sometimes people even say 6 months, right? So if it's present for at least 3 months, we know that we were hoping that the body would figure out whatever was going wrong, be able to dial it back in, doesn't have to compensate anymore, that everything can chill back down. Cool. Hey, Eileen, good to see you. Garrett, good to have you, man. Hope you're doing well. School's out, I think. Let's go with that. School's out. So what we want to make sure is that we don't have things that come and go. So like as part of the things that give you a fever, as part of things that can be an injury, we can see tachycardia as the normal part of that, the normal consequence. So if I've got a fever, I'm going to have my heart rate clip up because I'm going to have what's called hyperdynamic blood flow. I'm going to start moving it through faster, and that allows me to exchange more quickly, keeps blood from stagnating, and allows me to work through that sickness. So that's why we're wanting to make sure, like, is this something that is just acute and it's going to go away on its own? Or is it something the body's kind of struggling to work through, and we need to make some sort of an intervention because we're not getting a trend back upwards, right? So we're always looking for, can we start to get somebody trending back upwards so that they can get going again? Cool. Man, some of my favorite people popping in. Garrett's back in summer school. Love it. Crushing it. Lori English, welcome, welcome. Nicholas, good to see you, man. And thanks for being here, everybody. It's exciting to have you. So keep rolling. But that's step 2, is like, it's got to be chronic. If it's not chronic, that's kind of a good thing, because we're hoping that your body is going to figure out this problem, solve it, and then start to calm that stuff back down. If it's not trending right, then that's when we have to start thinking about what's going on. How do we intervene? Cool. So number 3, here's where we start to, like, for you guys, the people that are living with this, patients, this is where you're starting to look inward, and we're kind of looking at the orthostatic symptoms. This is your lived experience. Okay, this is the patterns of what you're feeling. So lightheadedness, dizziness, brain fog, fatigue, palpitations, tremors or shakiness, nausea. Nausea can be in different places. Some people feel it high, some people feel it low, more toward their bowels. Some people feel nausea in their head. They all count. GI upset, where you just like, oh, I don't want to eat. I'm not hungry. I don't feel good to eat. I feel really bloated. My gut doesn't move very well. I get constipated. I get diarrhea. It's a mess, right? And then left long enough, then we start to see those turn into different things like GI infections, SIBO, where we go on with that tissue being kind of hypoperfused for a period of time. Okay. So then number 2, let's see here. Okay, so another thing you're going to look at home. Okay, so you got your symptom base. Cool. Feeling these things don't feel right. A lot of them tend to feel like I'm either super amped up. It's not my favorite term, but people will describe it as feeling like they're in like a fight or flight moment. They just can't get out of it. They feel like their body is anxious, but they don't know why, right? So it's giving the signal that something is wrong, but I cannot put my finger on what it is. And those are the feelings that come with that. But the big one that happens specifically with POTS as its own box in dysautonomia is that the symptoms are worse standing up. Okay, when they're upright, it's harder. My heart starts beating fast, my symptoms get worse, I get a little short of breath, feeling a little dizzy, don't like it. Okay. But then when you lay back down again, things start to cool down. And that's this big signal that this whole reflexive mechanism that should be working is not firing on all cylinders. Okay. And when you look at those main differentiators, that helps us kind of narrow down specifically things that are going to be related to orthostatic symptoms. The main one people are usually trying to figure out is this POTS, right? Now, if it's not, that doesn't mean you're like up the creek. It just means we want to look at, okay, we have to solve this problem differently. We have to put a different hat on to understand what's going on. Cool? Cool. Okay, Michaela, I see you there. I'll get to the questions after I go through this part. KM Choreography. Good to see you. Glad you are here. All right, let's go to, so step 4, this is where we actually start moving people like into a clinical setting. This is where typically we're going to do some investigation, right? Obviously, in that first step, there's an investigation that's involved with that. Thinking about, like, do I need to run some blood work? Do I got to see if I got anemia? Do I got to see how my thyroid's doing, right? All of that stuff you're doing on the front end to make sure it's nothing else. Christy Lee, hello, hello. Oh, we got doubles today. Love it. And then, so here's where we're starting to look at more of the specific autonomic criteria. And a lot of times these are done in a more, like, I guess you call it a specialty setting, but this is more we're trying to drill down into. We've kind of reached the point where we're going, it's not getting better on its own. Dang it. We need to get some leverage on working toward a good direction. We need to understand what's going on better here so we can understand what to do about it. Cool. So big things are, we want to do things that kind of stress that orthostatic system. When I say orthostatic system, I mean the ability to be upright. That's orthostasis, right? So if I'm testing that ability to be upright, the main tool that we use is a tilt test. Also, when you have like maybe a little less like technical advantage. Hello, ladies. So when you have a little less technical advantage, then you may use something like a Nasaline test, also super useful, been validated, very good tool. Also a tool that you can use at home, by the way. But we use a tilt table, and we want to make sure that when we're doing that, we make it worth our while, and we're testing enough features of what's going on to be able to pull the maximum amount of data out so that we can understand the case. Okay. Yeah, so you're going to look for probably a 10-minute test. You're going to relax, 10-minute test. You also want to test again when we get back down. Dr. Ginia, I think you are on the stream. I saw you pop in. We are working on, Dr. Ginia's been working diligently on, we developed like a home version of the Nasaline test that's modified. So we did like a little Keiser modification to give us a little more data for things that people can do at home. So maybe she could talk a little bit about that. Maybe we pull her in, but definitely gives people some tools to start to investigate at home a little bit more about what's going on in a simplified way. She says, yep, I'm here. She's hanging out. And yeah, so we're working on that. We're going to try to get it out to you guys as soon as we can. Try to help out a little bit. Okay, so you want to be calm, relaxed. We're looking for these heart rate increases and no changes in, especially systolic blood pressure greater than 20, diastolic pressures greater than 10. And we're going to do like a little bonus moment right now. Melissa, welcome, welcome. So here's the bonus segment. So we've had a lot of conversations recently where people are wondering about the quality of connective tissue that they have. And if that quality of connective tissue makes people feel like a little floppy in the vasculature, right? So if we're saying I'm too loosey-goosey, I'm worried that my blood vessels are too loose and I can't tighten up. Cool. So how do we understand that a little bit? There's tests you can do at home that can give you a window into this. So you think about it, if we're saying that vessel is too loose, actually, let's do this. I'm gonna get to draw on here. We're gonna draw. Well, I don't know if I like this thing chasing me around like this, but we're gonna work through it. Okay. So let's draw. So if I've got a blood vessel, let's say, we're gonna make it red because blood. So let's say this is my blood vessel. Okay. And if I want to be able to be upright, the thing that I do, I got my heart up here. Whoop, that's the top of my screen, apparently. Let me back this down. So I got my blood vessel. I've got my heart. So if I want to push stuff up toward my heart, I need to make this tube more narrow. Agreed? Cool. So in order to do that, I've got to constrict this tube. What this would look like if you cut it in half right there, it would look like you've got a big tube that needs to become a small tube, right? Okay, so how do I do that? Muscles constrict. So if we're worried that that tissue is too loose and the muscles aren't going to be able to make it tight, well, one of the things that we can look at is the blood pressure. So the diastolic blood pressure is the measure for when the heart is squeezing blood out, right? So it's like if you thought about a squirt gun, it's when you're pulling the trigger, there's more pressure of water coming out of the trigger at that point. After the squeeze, there's kind of a relaxed time, right? So you squeeze the trigger on the squirt gun, it squirts, but then there's nothing for a minute. So the nothing portion is the diastolic part. That's the bottom number. And that nothing portion tells you about at baseline how tight is that vessel. So what you want to know is that vessel, if this is the vessel laying down, when I go to stand up, does it get narrower? Okay. And if it gets narrower, it means it can contract. If it can contract, it means that the nerve that goes to that vessel is working. And it means that it has enough integrity to be able to contract. So what we like to look for is, like, let's say your blood pressure is something like, let's call it 120 over 80, because that's what we call normal, right? So if it's 120 over 80, then we might see that when you tilt up, we go to like 125 over 85, let's call it. So that 85 means that we're able to generate more pressure at rest in between the squirts of the squirt gun, right? So if that's true, then that means this vessel has to be smaller to be able to create the pressure to push that fluid up the column, if that makes sense to everybody. Okay, so the little trick here is, one of the things that we look at is if we don't know if the vessel is able to actually create the constriction, like everybody talks about splanchnic pooling into your gut or venous pooling into your legs. If we're having this massive expansion, can we actually create enough pressure to be able to hold that? Now, the second part of that is the venous system just collapsing? And if so, then we'll see that venous distension as part of this as well that doesn't recover. Okay, but that's the first like little quick thing that we can do to be able to understand if we're capable of making that arterial change. So hope that helps. The venous side, you're going to have more relaxed. There's less muscle in that tissue. So we want to see if we're getting that distension that is not recovering. Cool. Okay. Back to the regularly scheduled broadcast here. Let me go back slides. Nobody look. This is a secret. Okay. So here's where we were. Robin, good to see you. Yeah, I know it's super late over there. You should sleep. Just saying hi. I'll catch up on this live later in the day. Thanks. I appreciate you checking in with us. Garrett, I see your question. I'm gonna flag it here and we'll rock and roll. Okay. So let's keep moving along. Hopefully that clears some of that up. So when you're looking at these at home, that is a thing that we can pay attention to. So we're looking at orthostatic symptoms. This is where testing can be useful. My opinion on this is I think that looking at heart rate and blood pressure is a great start. It is a great start to see it, kind of like what bucket we should start out in. But also, from my experience, when I used to do tilt tests, what I would look at was blood pressure and heart rate. But I would see people and I would evaluate them and say, like, this is not the whole story. I cannot fully understand what is going on based on blood pressure. I have no way to understand if the blood pressure here at the neck level, at the heart level, in the legs is the same as what's going on in my head. And so many people experience those hypoperfusion type symptoms. Like, I just don't feel like I'm getting blood in my head is a common refrain amongst the people I meet. There's so many people that experience that we had to be able to start to differentiate what is going on here. So that's where the next parts come in, where we start to actually look at that blood flow in the head. And then we talked about this last bit here, which is always, 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 you have to consider the medications that you're on or that other people are on, so that you can understand how those medications are pushing and pulling levers within the system. So for example, if someone's on propranolol, they're on a beta blocker. and we do a tilt test. The assumption is that that propranolol should drop that heart rate down a little bit. So we might expect to see that that tilt test is relatively normal. But what I like to look at is, while you are on the drug that's supposed to be helping, do we still see that there are problems writ large? And we had an example of this today. Those of you that are here know this, where you can be on the propranolol, but you can still see the drop in the cerebral blood flow. So even with an augmented system, we can still see that it's breaking down. Okay, so hopefully that helps. Okay, so that's kind of like, from a basic side, that is definitely the place to start. But what it can't tell you is what the cause is. It helps us start to congeal, right? To, like, stick together what the symptoms are, so that we can start to paint a picture of where we need to go and look. Doesn't tell us what's failing, doesn't tell us why the symptoms are there, but it starts to kind of pull together a story. And that story is really helpful for then understanding, what do I want to do to investigate that story and see if I can start to pull on the thread of the mechanisms underneath it. How does this machine work to be able to understand the symptoms that go with it? Cool. And I think that part, I say it constantly, but I also feel like I can't say it enough, because I feel like if I try to analyze what I find to be the most helpful thing for people, it's that. It's can we do a better job with what is underlying it? And then can we train that? Can we make it stronger? Can we make it better? That's the meathead in me that wants to say, can we take a weak thing and make it stronger? The answer is for so many people, yes. So that's kind of like, that's where my head goes as a solution for a lot of people. Okay. So part 2, this is the part that we kind of started into last week, is starting to think about the subtypes. Number 1, the common one people talk about, there are 3 common ones. And then what I'm going to do is give you how I feel about the 3 common ones, based on some experience. And then we'll talk about some additions to that give a little more clarity on what's going on. Cool. So neuropathic just means that there's a problem in the nerves. So if the peripheral nerves start to have damage, the autonomic nerves or the small fiber sensory nerves start to have problems, then our brain can send the signal down, but we may not be able to actually execute with the motor activity. Going back to that diastolic pressure, we'll see the diastolic pressure starts to drop when somebody's upright, when we have these neuropathic types. And the other part is, on the sensory side, I may not be able to get the signal about what's going on with the blood flow in my body. And as a consequence, I don't know when it's bad. So my brain doesn't know to try to go down and solve the problem. So those are 2 ways to think about it. Okay. Number 2 would be thinking about hyperadrenergic POTS. People call it hyperPOTS, where you get this discharge of generalized sympathetic activity. So remember, sympathetic nerves should act independently. Each one has its own function in its own region. So it should do its job in its region, shouldn't have to bleed over into other areas. If we see that 2 different functions start to bleed together, or different regions start to bleed together, then there's a control system problem. And that's what we're looking at here. It doesn't mean that that is the thing that's failing, even though conventionally that's the way it's treated. It's saying, like, oh, that's too high, let's knock it down. But instead, we can look at it as that increased activity trying to overcome or to create an adaptation to keep you trucking along through your life. Okay. So these are often compensatory from cerebral hypoperfusion, autoregulatory failure, problems with baroreflexes, which are these little sensors in the arteries of your neck and in your heart and in your brain and in your kidneys. And they sense the blood flow in the artery to give you a real-time feedback on how much change, like every beat, the arteries of your body are like shifting dynamically to keep the blood flow linear. Those are the systems that help us do that reflexively, so there's no extra energy needed. Cool. And the other one is related to our breathing. So when we start to get problems with carbon dioxide ratios, or the patterns of our breathing are interrupted, then we also see these sorts of failures here. And what we're looking for is different systems that are bleeding together. So the common, easy example would be like the thermoregulatory system and the blood pressure system. So both of them involve blood, but out toward your skin, all that blood is designed to help you be able to manage your temperature. So if it's cold, it pulls the blood away from your skin. If it's hot, it pushes the blood toward your skin so that you can use that convection activity to maintain the temperature. Whereas in the muscles, that's being designed to just keep the blood circulating to all the parts of the body, keeping them fed. If those start to bleed together, then we know that that's problematic. Okay. It's just one example. Same thing if we start to see GI problems, or we start to see genital urinary problems, or we start to see bowel movement problems. Those are things that don't necessarily tie directly to that circulation of the blood supply. Make sense? Cool. So just to recap, we want to think about it as what is that sympathetic system compensating for, where it's saying rather than being specific, we're just going to crank all the dials to 100 and try to get this thing to operate. The third one on the list is hypovolemia, which is just an idea that there's not enough blood in the system. Problems with this are that your right atrium, if it's working well, the sensors are working, can detect changes of as small as like 1%. So it keeps a pretty tight range. Our renin-angiotensin system keeps a really tight range on how much salt is in the system versus the water in the system to keep the concentration right so that we don't get too salty or get too watery. Easy way to say it. A lot of this starts from a 2005 article that was talking about low blood volume. It's hard to measure without bleeding somebody out, but you can do some ways. None of them are clinical, meaning you're not going to go to a doctor and have one do that, like measure your blood volume with any real accuracy. But the thing that was really important was blood volume, as they measured it, even though they measured it, they feeling like it was low based on the proxies they used, it didn't actually correlate with the symptom severity or the hemodynamics. So I think the big takeaway on this one is we don't want to think about it necessarily as like someone didn't put in, like your oil is low, so like your blood volume is low. We want to think about it as it's not being distributed appropriately. So if I've got blood that is being distributed in areas of my body and then not returning effectively, it's going to look as though I have low circulating blood volume, even though we might just be having some static blood volume change. Like we're just not returning it well enough to the heart. We're not controlling the underlying system very well. Those are very amenable to what we think about with the maps in the brain and how our brain controls that vasculature reflexively with no effort from human beings. Cool. Cool. Okay. And this is just a little bit more kind of going into that. Basically, yeah, I kind of talked about this a bit last time. One of the rationales that's given is that, hey, when you give people saline, they feel better. So it must be they don't have enough blood volume. When you give normal people saline, they also feel better. So it's not really a very good metric. And then also you can't do that forever, and it creates other problems when we try to do that. So that's probably not a good way to think about it. And then obviously this 2004 article from Stewart's awesome. Julian, and the symptom severity didn't necessarily correlate with the measured blood flow in the cerebral blood flow with transcranial Doppler. So you're seeing this disparity between what was considered, if we just have low blood volume, then that low blood volume should be distributed equally amongst everything. And what they were finding was like, well, it looks like you got low blood volume, but it doesn't match like what people feel, nor what we measure in the cerebral blood flow. And that's been my experience too. So I look at it more as a dynamic hypovolemia, meaning it's poorly organized. So even though you may have enough blood, it's not being distributed effectively. Cool. And then, so this is when we kind of add to it, and this is less common. So if you're new to the world of POTS and dysautonomia, I think this one is going to be useful. So hypocapnia is when we have our CO2 levels, carbon dioxide levels. You think about carbon dioxide concentrations are higher in the air you breathe out. And the reason we breathe that air out is because when you have metabolism, mitochondria, right? So you guys have probably heard of these magical mitochondria that help us to take oxygen and glucose, turn it into energy, water, and carbon dioxide. We kind of get rid of the water and carbon dioxide as outputs, and then we keep the ATP or the energy that comes from that. So part of getting rid of it is sticking it back in the blood and then breathing it out on the exhale. And the interesting part is we don't just want to get rid of all of it, which is kind of, there's a little bit of irony to that. We need to have a stable base of it to be able to maintain concentrations. And so when the levels start to get too low, one of the things that can happen is it actually starts to cause vasoconstriction within the system, particularly in the brain and in the periphery, like around in the skin. And then if the levels get high, then we see that they dilate, which is kind of useful. So if our metabolism is really high, we're going to dilate, flush new blood in. If it gets too low, then we're actually going to start to see it go down. Very good. So we see these with EtCO2 measurements under 30. We actually use, this is from a different source. We actually use under 35, but we use like the 32 to 35 is kind of a gray range. If you start getting under 30, then it's a significant change in EtCO2. We can see this also with changes in the breathing. So if I breathe faster, which you'll notice that you kind of want to do, then that may blow off more carbon dioxide and further drop that CO2 level. Or if you take those big deep breaths, like, and you do that a little too fast and you start to feel a little woozy, the reason is because you're blowing out too much CO2, that number drops down, we get vasoconstriction, particularly in the brain, and we reduce the blood supply to the brain. So this, for some people, can be a contributor to some of their symptoms, okay? And then the last one we're going to talk about is the one that I think is probably the most crucial, which is understanding hypoperfusion. Now, OCHOS, or orthostatic cerebral hypoperfusion syndrome, is when we say the cerebral blood flow is dropping, but the heart rate and blood pressure are within normal. Okay. And so in those cases, we are looking for these drops in blood flow that you may not see otherwise. And this happens with a lot of people that are in this gray space of like, my numbers don't quite qualify for POTS, but I feel all the symptoms of it. Here, this is talking about greater than 20%. The number that we tend to use is somewhere around, we actually use a little bit more finite number. We use a 10% drop in the first minute and a 15% drops subsequently. And then we use 20% with head rotations. So just like some nuance to that. But they look a ton like POTS. And one of the things that we see a lot is people that experience POTS also experience these drops in cerebral perfusion. And that is one of the things that we are really targeting to say, we want to know, how do we get that cerebral perfusion, blood flow in the brain? How do we get that back up as our first job? Saying like, you know what? Turns out brain works a lot better if you can get it some oxygen. Everybody knows, or maybe they're not aware of, but you know it intuitively, that if you think about someone drowning, someone's under the water too long, let's say they're in the water for a couple minutes, the thing that we worry about is not like that their leg gets sore. What we worry about is there's not enough oxygen going to the brain. And that's what causes the big problems, right? We put them in a coma, we can have brain damage, we can have death. What does that tell us? It tells us that the organ that is the most sensitive to oxygen is your brain. You cannot go very long without replenishing the oxygen into the brain. So when we have hypoperfusion, where we're decreasing the oxygen to the brain over time, this starts to cause problems with the function in the brain. This is like probably the core feature that we pay attention to first for a lot of people, because we want to say, if we want the brain to work well, first step, you got to get fuel to it reliably, not just when we're laying down, but all the time. And hopefully that makes sense to a lot of you in terms of like, if I want to try to heal, I've already shown that my body is just not able to start to heal. Maybe part of that is my control system, my computer that is my brain. If I'm constantly just running it out of gas, it's not going to be very good at doing its job. It's going to get tired more quickly. It's going to be less active. It's going to be less accurate, less stable in its output. And I think if we put it in those terms, a lot of people start to be like, yeah, that sounds about right. Because like I get tired really fast. I start to wear out, and then like my brain feels like it stops working. I can't think. My memory goes to pot. I get disoriented. I spoke with the Nomad Over Normal team today. Great squad, by the way. Everyone give them a shout out. Great people. You'll want to know them. But we talked about this understanding of the term disorientation. What does that mean? It's that kind of feeling like you are not in your own world, right? And I think that that is such a common sensation that is described to us as people feel these symptoms of orthostatic hypoperfusion. And when you don't feel like you're in your own world, it's not just that you feel kind of vacant, but you can't participate in it very well. So it's hard to think. It's hard to like, be able to work through a problem. It's hard to be able to make decisions. It's hard to be able to feel like you have confidence in what you're doing. So all of these things tend to make people feel super vulnerable and super like unsure of what they're doing. And there's also an anxiety that comes with feeling disoriented. Like if I spin you around in a circle and you don't know where you are, or you wake up in the middle of the night and you're like in a hotel room and you forgot and you get disoriented, like those are things that your body instantly will start to feel like, I don't know what's going on. I don't know what it is, but I feel uncomfortable. And for a lot of us, the word that we put on that or that we attach to it is anxious. Makes me feel anxious. And I think that that's probably a reasonable word. And I think it's reasonable that people feel that way. So I also think that we should stop telling people that they're just anxious, because the just anxious part is one of the biggest clues that something's wrong. If you're anxious, there's something wrong. Let's figure that out. Anyway, so that's over. But I do think this concept of disorientation, as pointed out to me by the Nomad Over Normal team, is a very important part of understanding some of these feelings. Okay, so shout out to them. Thank you for kind of pointing that out and giving me something to chew on with thinking about that. Cool. All right, so here's our summary, and then we're going to start to take on some questions. We got a few loaded up in there. We'll get to those first. I'll just try to go in order. If anybody knows the people at Restream or the Chat Genius, we need them to go ahead and have a separate question chat box and then like a chat box that's real time, so I can see what people are talking about in the moment, because I get lost in them and then I don't get to see like the comments as well. So let's figure out how to fix that. Corey, you on here? Put that on your workflow. Really appreciate you. Corey's genius. Everybody should also know Corey. Follow him on all of the socials. He's good people, and he's going to solve all these problems for us. So anyway, so the summary here. The basic diagnosis is necessary. That is the starting place. Get there. But a lot of that, as you can see, can be done before we even get to the point of needing to get to the specialist, right? So it's kind of like we should be crossing all that off, also hoping that maybe this just my body starts to figure it out, starts to heal on its own, and then we go. Okay. Thank you, Corey. Appreciate you getting on that. But I would say that the basic diagnosis is just a starting point. It's not where you're trying to end up. So like, I know it is satisfying, it's validating, it feels good to have the diagnosis because you feel like you got something to hang on to, something to tell people what's going on. You don't feel crazy. I get it. But also, we need to use that as the jumping off point to get to where we're actually trying to go, which is feeling strong, feeling healthy again. Okay? Cool. So when we start to dive into subtyping, rather than thinking about the subtypes as the overall problem, we want to think about them as the compensation. So what is happening in the compensatory systems that allows the body to be able to try to solve this problem on its own, okay? And if we can try to solve that, or if it's trying to solve that, you can see where those edge cases are and figure out what the mechanism is and help the body train that through, okay? And then this just talks about our approach. We're using transcranial Doppler, capnography. We're trying to use as many tools as possible in that process to fill out that functional picture of understanding what's going on in the body. And as we do that, more data. There's this good quote. There's a quote from Wayne Dyer. Wayne Dyer is like an old school like mindset. I'm not going to call it a positive thinking, but it's kind of got that vibe. But what he said was, what you measure, you manage. And so if we can't measure it, it makes it really hard to understand if there's something wrong. And it makes it even harder to then know if you're improving it. So by doing things where we can palpably measure what's going on, number one, it helps people have like a base in reality. They feel like, okay, like there is the thing. But it's also not, it's not just for that. We want to see, can we do things that make it change? And if you can measure it and you can measure outcomes that bring it up the scale, and we can go from being in that like static state where my symptoms are just hanging out or even getting worse, and we can start to bend them upwards, that's a huge win. Because as soon as we start to get that catalyst where we're bending it back up, now we know body is responding. Body is like got something new to grab onto to try to heal itself again. So that's my perspective on it. So I'm hoping we can start to think about, sweet, POTS is like a starting point. Dysautonomia is a starting point. Post-concussion syndrome is a starting point. And then from there is where we start diving in and start trying to figure stuff out. Okay. That is my concept for today. So I'm going to pull these down. Let me know if you got questions on any of that. And then I'll start taking questions from you guys and we'll rock and roll. Cool. Corey, thanks for getting on that. Love it. Dr. G. Wayne Dyer's the best. I'm a fan. Also, sometimes when people get like in this setting, like the stuff where we're kind of cheering people on can sometimes make people feel bad. So I don't want to do that too much. But if you need a little cheering on, maybe some Wayne Dyer help you out. Okay. Let me see. Right on. Okay, let's scroll back up here because I know I had straight off the bat, Matheson. So I don't remember if you are in the US or I thought maybe you were further away, but I could be wrong. So how do you determine if POTS is caused by a neck injury or a vestibular issue if they're both present? Fantastic, stinking question. So we talked a couple weeks ago about the role, we brought up a paper and they were talking about the role of cervical proprioception and the impacts that it has on symptoms that may be cervically based, but it can also cause symptoms in what we experience from the visual system, our sense of balance in the vestibular system, and even outputs into the way that we start to think. So the question would be is, if you have an injury, which is common, that can affect the vestibular system, usually these are ones where like we're whipping the head around in some way. So I get tackled, maybe my head gets twisted, maybe I'm in a car accident and I get this big old whiplash, right? Maybe I fall and smack my head. Like most of these things that people injure their heads with usually also would accompany this like, torsional movement of your head where your head is rotating. And when that happens, that tends to be the catalyst for the symptoms that are experienced the most. So usually like if you look at a head injury, someone that smacks their head straight typically doesn't have symptoms that are as bad as somebody that smacks their head with a twist. Simple rule. It's not a heuristic. It doesn't apply to everyone, but that's like a general tendency. So if we have something that can cause like a vestibular concussion or it somehow affects the vestibular system, then there's a probability it also affects the neck. I think that's smart. So when we look at these, there are ways that you can differentiate by isolating the two systems. In other words, so like if I do a test, I think this camera is going to chase me, so hopefully it works. But if I do a test where I turn my head and my eyes aren't able to keep up, right? And they like bounce around, I could be thinking to myself like, uh-oh, they might have a vestibulo-ocular reflex that's broken. That vestibular system can't talk to the eyes, and the eyes don't catch up, right? But it could also be that my neck's giving me bad feedback, and when I move, it just creates a static that causes my eyes to bang around. So one of the simple things you can think about, and we're just going to use this as an example to kind of speak to a bigger one. So if I find that like when I turn this way and my eyes start banging around in there, they can't catch up, I can also do the same thing where I keep someone's head still and I can rotate them, right? I can rotate a person and I can see the same thing. So I can put them in a chair like I'm in right now. So I can turn their head. That doesn't work well. But then I can say like, but if I rotate them without turning their head, I'm not activating that neck, but I am activating the vestibular system. So I can separate them out, right? And then additionally, I can say, I'm going to hold the head still, and then I can rotate their body without moving their head, right? So now my vestibular system is not going to be active, but my neck is going to be active, and I can start to look at that. And then I can put the two together and I can say, follow my thumb. And I can say, when I have to use my eyes and my neck together, how do they coordinate? Am I able to hold the target? So you start kind of pulling the systems apart. And if you think about it like that, you can do that with any systems that you're trying to compare to each other. So you're saying, do they work on their own? Does one work on its own? Does the other work on its own? How do they work together to start to sort that problem out? All right. Same thing if you're trying to differentiate if it's a problem, in the oculomotor systems with the eyes. I move the eyes on their own. Can I hold gaze? Can I pursue? Can I do optokinetics? And how is that different from the vestibular responses? So awesome questions. It gets a little bit deeper into the weeds of the diagnosis, but that's why you want to look at it all writ large. And if we had another layer to that, which you didn't ask for, but I'm going to do because I want to, we could say in these autonomic cases, we want to know like, all right, that VOR seems to be gross, right? It's not working very well. They're getting dizzy, but they're also getting this tachycardia. Is that causing the tachycardia, or is that something else? Well, we can do the same tests, but then we can put the leads on, or we can put a pulse ox on, or we can put a Doppler on, and then we can measure if when we're doing those same tests, does the heart rate come up? Does the cerebral blood flow go down? And we can look at how those things start to interface. Cool. Awesome. I hope that helps. It's a really good question. Thank you for asking it. Second one on the line. So that one came in screaming from the beginning. Thank you very much. Okay, let's see. I'm going to scroll down here. I answered that one. Michaela, welcome. She wants to know, do you treat people with autoimmune autonomic ganglionopathies? So these are very interesting. They're kind of rare. And what the question would be is, so sometimes people will have autoimmunity toward the ganglion of the autonomic system, which tends to be cholinergic. In these cases specifically, you see pan dysautonomia, where it drops the function of everything. So we talked about hyperadrenergic POTS, where it ramps up and generalizes sympathetic activity. In this case, you're seeing generalization of the sympathetic activity. Oh, moving camera again. There we go. We're seeing generalization of it, but and it's taking it down. So in these cases, you see super low blood pressure, lower when they stand up, blowout on the diastolics, right? But you also see not only on the sympathetic, so then like I also get no oil in my skin, super dry, hair starts falling out, skin is really papery, really tough, very pale. So we're just not able to activate the systems of like thermogenesis of like feeding the skin. But then also you're going to see the parasympathetic fibers, or the parasympathetic outputs, are also going to go down. So we've got dry eyes and we've got a dry mouth. And it's not because they're stressed, it's because it doesn't work. The ganglia don't work. We start to see problems in the organs, in the kidneys, and in the liver, and in the pancreas, and in the adrenals, because they're not getting fed well. The gut just falls apart because we can't get a signal to the gut. So it takes the whole system and brings it down. And this is the typical like familial style dysautonomia, but it's usually an acquired one that is autoimmune. In these cases, number one, they're going to look for, do you have the antibodies? And then number two, what they'll typically do, because the immune system will be chaotic, they will oftentimes use IVIG to be able to try to see if we can give you a supplemental immune system, basically like a mercenary army to come in and to be able to decrease some of that autoimmune response and see if that helps to elevate some of those functions again. It's a particularly tough one because over time it deteriorates the activity in the ganglion. So those tend to be tougher. Now, I think a lot of people also get overdiagnosed with these as well. So you want to make sure that the autoantibodies are correlating with the symptomatic expression, and we don't have a variant of antibodies that is not matching what is actually going on from a functional perspective. And that part starts to get a little bit nuanced. I'm happy to talk about that too. I got a little girl whispering from the stairs. Good night. Good night, love. Lavender lemonade. Oh, questions for later. 2 questions, but I see. Oh, okay, here they are. Lavender lemonade. I like that name. Where's your clinic located? Chelsea, Michigan. Can you heal the small fiber neuropathy? We want to make sure that it's small fiber neuropathy. We want to know why it's there. We want to know if there's an active injury occurring, like something that is beating it up right now, or if it's something that it came through and it is gone, and then you're trying to get it back on the other side. Obviously, you can't tell on the internet if that's something you can do. Maybe a better way to answer that question would be, do people heal from small fiber neuropathy that I've experienced? And the answer to that is yes. But does that mean that you will or that I know how to do it on everyone? I don't, because I don't know what it is. But I think if you know somebody that's working through that, you shouldn't look at it as if the algorithm is, can you heal it, yes or no? And I would say that there's a higher probability of yes than no. That's my politically correct way to answer that one. Cool. Garrett, what class do you take in the summer school, man? We getting econ? We're just doing options degeneracy? Let me know. Oh, Eileen. Oh boy. Ready to move the needle. Coming to see you next week. That's exciting. Love it. Can't wait. We'll be ready for you. Open arms and hugs. Kayla. Oh, okay. That's like the second version of that question. Garrett. Okay. Garrett, question for you, my friend. Question that maybe resonates with others. Is there a connection between blood sugar imbalance, temperature regulation, POTS, and the neck? Seems like blood sugar symptoms are more prevalent in the Arizona heat. Oof. Love this question. So, because when we think about moving blood through the body, I want you to think about like the reflexes that just are mechanically moving the blood. But also part of the function is we're trying to distribute energy. We're trying to distribute the precursors for energy, which are largely glucose and oxygen, right? So if we're getting oxygen demand changes, it also means that we're likely getting changes in glucose demands. Now, some of you will also point out, yes, but there are, lactate shuttles, and there are, different components of ketones that help us out. Very true. But also we use glucose. So one of the things that can happen when we start to look at these relationships, we'll start with number one, is blood sugar imbalance, temperature regulation, orthostatic tachycardia. These things shouldn't necessarily be related, right? Because they all have their own control systems. But if we see them starting to generalize, then what we can do, and especially if we see them in phase changing, then we want to look at what if we step back and look at what controls all of them at one time, then that helps us understand, like, maybe we actually have a coordination problem where we're not coordinating these things well. Where does the neck fit with that? For some people that have instability or proprioceptive error, that error in the neck can give faulty feedback about how those nutrients are being distributed, and we may not be getting signals about the accuracy of that, We may also affect downstream effects that are going to go to the pancreas. We may have injuries in the neck or in the upper back that may be affecting the signals that go out: pancreas, kidneys, liver, gallbladder, spleen, all of these things. Remember that they have nerves that come down from the brain. So anything that can interrupt that has a probability of affecting these things writ large. Now, usually they'll be, if they're in that kind of downward spinal system, then they don't tend to blend together as much. But if they're coming from these outputs from the cortical reticular system, then we're going to see them start to bleed together. This is a really good point. Gary and I talked about this a couple of weeks ago, and I think it's important that we also are doing things to help people manage blood sugar. But you're right, in heat, you're going to have distribution of blood that's going to be different. It's going to your skin a lot more. So we have to be able to do things that slow down the conversion of blood sugar and insulin release. So it's eating small protein-based meals, eating every couple hours, not too much at a time. And then also making sure that we're doing things to help you manage that heat. So being able to, stick your arms or your feet in the cold water to cool off and regulate that, or to be able to dunk your face in the water and regulate that, can help as well. Really good question, and something we're investigating, especially with the onset of continuous glucose monitors being more available. I find those very interesting in these cases, for sure. Thanks, Garrett. We really appreciate you, bud. Okay. Robin. Oh, yeah, that's right. I'm sorry. Robin was saying hi and then off to bed. I'm guessing, Katie, you were mentioning this when we were talking about low blood pressure. 84/41 is pretty low. Let's get that up. That's not hanging on by much. That's a tough way to get through it. So blood pressure up and away. Por favor. Ooh, okay. So Elsa, is it still POTS? If diastolic goes up on standing or tilt table test from 80 to 100, it can be. One of the main things we're looking for, good question. So you're asking if like the blood pressure going up augments the criteria of POTS. So what I'll say to this is the technical basic version of POTS, basic criteria, no. We're looking for to see if it drops. If it drops, then that kind of takes us out of the basic POTS diagnosis. If it's going up, though, it adds to our understanding of what is going on. So if we start to see that diastolic pressure is rising, here's what I like to look at. If our heart rate is going up and our blood pressure is going up, I look at a couple things first. Number one, are we anxious? If we're a little freaked out, we're a little nervous, we get a little panicky, those things are going to come up, but they all come up in concert. And you guys have seen what this looks like, right? So it's all coming up in concert. We can measure that on a tilt, and we can see if those dynamics are changing because it's orthostatic or because we're worried about it in general. And that's part of why we give people that time in the beginning to just kind of acclimate to the environment. And then we compare that to what we're seeing in a Valsalva maneuver in a deep breathing test, and we can use that to differentiate. Whoa, what did that do? Just zoom me out. What was the magic hand signal I did? Whoa, no man over normal. I need you to come work on this screen for me. Let me see something real quick. Hold on. That was fun. I gotta turn off these hand signals. That's wild. I don't even know what we did. Gestures. Let's turn that off. Okay. Back to the story. Sorry. Thanks for waiting. Okay. So where was I? So, okay. So we're trying to differentiate. So is it anxiety? That's the first thing, because people get scared. They get nervous. It's a big deal, right? It's reasonable. But we can tell by correlating the rest versus the tilt versus the deep breathing versus the Valsalva, and we can understand that. So the second part is they're not nervous. They're not breathing weird. This is like a function of the way their body's doing it, where I start to see the heart rate go up and the blood pressure go up. I'm going to start thinking about things related to the brain from the cortical reticulospinal system. And we're going to start looking at other reticular signs, cranial nerves, outputs into the horn. We want to see if the reflexes are hyperactive and spreading. We want to note if there is hypersensitivity to pain. That's number 2 is this a problem with the inhibitory barrage from the brain? These are more in brain injury type cases, concussion, brain infection, those sorts of things where we know that there's component. You'll probably see that the pupil, there's a pupil asymmetry that comes with that too. That can also be a big indicator. But then the third that is not talked about as much is if I'm seeing the heart rate and the blood pressure rising, but then I'm also measuring on a Doppler system that the perfusion is dropping. That's like a big waving flag indicator where I want to look at, am I restricting flow into the brain? In other words, is there a clog? And the clog may be inside the artery. These are like, when people got too much plaque in the arteries. But a lot of people we see are young, and that doesn't tend to be the thing that's wrong. They get them checked, the angiogram's clear. But we can see that when someone's in a position on the tilt, usually they're laying back a little bit, their head might be tilted, or they might be in a position like that, where they actually do cause some constriction, where we push on the outside of the blood vessel and it makes it hard to push it up into the brain. People will notice that I feel like the blood is coming out. They also might feel a tension in their neck or like a heavy beat in their chest. In those cases, when we see high heart rate, high blood pressure, low cerebral perfusion, and we see everything that looks like it's just getting blocked coming in, then we start looking at different head positions, seeing, does anything make it let go? Does it allow it to come through? Does anything make it worse? And then we can differentiate from there. Cool. So you're ruling out, are we anxious? Are we a little worked up? Pretty normal. Happens all the time. Happens to me. Is it something where we're really looking at a brain-based problem? Or are we looking at something where we're actually causing constriction of the arterial system going up into the brain? So that's our place to start. Doesn't mean those are the only options, but those are the things we want to make sure we're going to rule out before moving further. Right on. Good question. So, but the answer to the first question is if your heart rate's going up, but the blood pressure goes up too, technically in the basic form of that diagnosis is still going to be a basic POTS diagnosis. It'd be like POTS and, and you get into the mechanisms. Okay. Eileen was commenting about, yeah, a lot of people. So I think where a lot of people find me, and maybe you guys could speak to this. Eileen was saying that no one's believed you for 2 years, not enough blood in your head. A lot of people will say, like, it feels like I don't get blood in my head. We should listen to that because a lot of them are precisely right. Okay. Soapbox. All right. Bella. Ooh, we got a long one here. I don't get it all on the screen, so I'll read it all out. I'd love to understand why heat affects POTS so negatively in some people, please. In hot weather, after a couple minutes trying to walk or do anything physical, my heart rate will go to 160 and I'll feel pre-syncopal, which feels like I'm going to pass out. I feel sick, very breathless, etc. Compared to winter, I can comfortably do a 2K walk with very low and manageable symptoms, and my heart rate max is about 140. I also feel more symptomatic in the summer even when not doing anything, just being in the heat. I feel trapped in the house all summer. Somehow hot tubs in the winter don't have the same negative effect. I think that is a good synopsis for how a lot of people feel, especially now that we're heading into some summer months. People are going to notice this more. Now, to be fair, to a degree, most people will feel a little lower energy in the summertime. They will feel a little bit more sluggish. So there is, we all have the capacity for that. But when we have that capacity that gets drawn so far down where it's like I can't tolerate it at all, that's where a lot of people are living here. We always talk about if we already have a low budget of circulating blood flow, like I'm just not circulating full volume, and then I spend some of it trying to dissipate some heat, right? Everybody's seen a dog pant in the heat. Why do they do that? Because they're convecting, they're dissipating some of the heat into the atmosphere, right? Just like using a fan if you're sweating. So we do that. We push the blood. That's why our cheeks get red. That's why our arms get red. That's why we sweat, so that we're trying to dissipate out some of that heat. In the course of that, Sweating is obvious because you can become dehydrated, and people are pretty well aware of that. But then also we have the amount of blood that pools into the skin, dermal pooling into the skin, which can also, if it's pulling it out of circulation, can make you feel crummy, right? So it can exacerbate those symptoms. So how do you work through that? Number one is we've got to make sure that we do everything we can to make sure that just the normal system is running toward optimum. If that's true, but we're still kind of sidelined with this heat component, the other part we want to pay attention to is if we're sweating. If we're not sweating or able to dissipate the heat, our core temperature can go up, which also causes symptomatology to occur. It's going to affect blood pressure. It's going to affect blood glucose, like Garrett was talking about. So that core temperature becomes important as well. And then the third part is if maybe I can sweat, but I'm getting enough of that distribution into my skin, maybe I'm to the point now where I need to start actually training that part. A thing that we don't consider a lot is if you don't feel well, you tend to stay inside a lot. And when you tend to stay inside a lot, for most people in the Western world, in the current times, we live in a pretty temperature controlled life, especially in your house. It's usually pretty much the same temperature because we've got thermostats and air conditioning and heating, blankets, clothing, etc. So most people are used to like a pretty tight range of temperatures. Okay. Now, Bella's talking here like I can do cold, great. Why? Cold takes all the blood out of my skin and puts it into circulation. So it's like I get a little boost, right? I get a little add on. So that's why a lot of people that have alterations in circulation, if we push it in so that it's all going to organs, heart, brain, they do a little bit better in the cold, and that's pretty common. But it also, on the flip side of that, also tend to get more Raynaud's type symptoms where my hands get, like your hands get super cold, your feet get super cold, but you feel better in your brain. Cool. Okay. But if we're at the point where we're saying, I want to train that, I need to get better at heat. Experience. So one of the ways you can think about doing it is by doing some artificial heating and cooling, this like exposure, where you're increasing your exposure to heat, giving yourself a moment to adapt to it and just like let your body try to get used to it. And then once you feel like it's not quite making it in a calm way, then we start to add in exposure back to cold. So it's like being in the heat. One of the common ones we'll do is we'll have people be in a warm heat, usually like morning time. It's like sunshine before 9 or 10 in the morning when it's not super hot out, but it's warm. And then we'll have you handle that as long as you feel comfortable. Usually it's easier if you're moving. And then we have you stop and like put your feet in the cold water or put your hands in the cold water. It doesn't have to be like an ice bath cold. It's just got to be cold for you. And if you can put it in that cold water and allow some of that heat to convect out, so you basically are cooling your temperature down again, then you can start to push the edges of what you can tolerate. But there's kind of three parts if you break it down. You want to expose yourself to the heat. You want to give yourself a moment to let your body try to detect the heat change and to compensate for it. So you start really low, small changes. And then you allow it to recover by using the cold temperature to affect like cold in one area to dissipate or downregulate the heat in other areas. So I can stay in the heat a little bit as long as I give myself a way to cool out. It's kind of like you're hot in bed, but you stick your leg out of the covers. You know what I mean? And you allow yourself to cool down that way. So that can be one way we start it. We go through this a lot with helping patients figure this back out again, but it's definitely for some people, a lot of times this is like the last little piece is that you're just waiting for that. When we used to be in Atlanta, I spent a lot of years working in Atlanta, which is obviously a different climate. And in the summer times, that was the thing that people battled. And I can still remember getting people outside and like how excited they would be like today was the first time I sweat in 3 years, you know, and so even though it's hard, sometimes like a measured amount of training it can be really helpful in kind of breaking through that difficulty layer to get your body to compensate again. really good question. Thanks for spending the time on it. I know that's not for everybody, but I think this season, a lot of people start to notice the same thing. I'm a dog too. I love these names. Hello, doctor. Your video about eyes and brain when sitting and standing changed my life. Thank you so much. I'm so glad to be able to contribute, and thanks for sharing that for us. I really appreciate it. And then Catherine. Catherine. I'm not sure how this works, but the thing that, quote, healed me the most for POTS was training my body to feel safe again while triggered or having symptoms, I think is where the rest of this one goes. Yeah, for some people, that can be the case. But I would wonder if it's like if we get into the basic diagnostic portion. So a lot of times if we look at arousal systems as being the main culprit, then the things that we will see, we can find them and we can know if we should be aiming at that as the problem. Tend to be around this generalization of symptoms. So the things that you would normally experience, like if you were to stand in front of a room and be nervous, where my blood pressure goes up a little bit, my heart rate goes up a little bit, I get a little bit dilation in my eyes, my hands start to sweat, where these things start to all couple together in a way that they typically would not. And in those cases, you want to see if they are related to orthostasis or if they happen in non-orthostatic climates. So like if you notice you can get the same symptoms doing other stuff, then there's a high likelihood that it's not purely the reflexes of standing that are causing the problem. And I think that part's really important, is differentiating, is this purely me standing up and the problem is from orthostatics, or can I also yield those same effects by doing other things, especially if you can do them in context about things that you're thinking about or you find yourself anticipating, or things that you're nervous about or worried about. And if you can see those same things happen and it affects the system without you standing up and it doesn't recover when you lay back down, that's a really good clue that this might be kind of part of the solution for that. Okay, cool. Cool. So I do think that there's a correlate that is like the Venn diagram of POTS is put in things where it's not purely POTS, but that's the language we're using. So in a lot of the like things where you're training yourself to be calmer or to alter your self-talk. Usually we find that if we dig a little bit deeper, the way that those present both symptomatically and through measurement, objective measurement, we usually find that it's not specific just to the reflexogenic system. It's more related to your brain attaching a level of attention to things that are more ambient. So things that are not just reflexive, but interpretations of how your thoughts or events in the world cause that arousal system to activate, and it becomes too sensitive to that activation. These are the tools that are helpful there, and we had some great conversations even on this live with people that have been through things like that, and how. But also, it goes to what we were talking about, is that taking the basic POTS diagnosis doesn't get us there, but if you can evaluate it deeper and understand the things we just talked about, then it's easier to say like, well, you should go do that. And then otherwise people will do it because it's low hanging fruit. They'll go, to primal trust or DNRS, but it may not be the thing because their problem is a reflexogenic problem. So I think that's a useful way to think about it, if that's helpful for people. So the criteria, I'll go through them again. If you're noticing that everything expands at once and it's not strictly coupled to heart rate with a stable blood pressure, you're going to notice other things that are happening: sweating, heat, malaise, fatigue, pupils, sweat. And they're going to be decoupled. They're not going to be purely related to orthostasis, but they're going to be more related to things that are transient event based, and they're not relieved when you lay back down. That's a good indicator. I can give you more, but that's like stuff you can do at home. Cool. Thank you so much for sharing that, Catherine. Good to see you again, by the way. Okay. I said something that Positive space set, 100% accurate. I'm sure you guys got to that way before I did. Oh, we're talking about disoriented. Yeah. Yeah, let me know what you guys think about that word. Maybe we could start to use that more in our nomenclature to describe what people are feeling. Nomad over normal. Big shout out to them for helping us out with that. Really insightful people. I really enjoy them. Oh, I was just clicking through. Dr. Genius says, hi, Laleen, excited for you to Michigan. Corey is on it. He's also developing. I'm just going to start sending you everything that we need to fix. Appreciate you. Corey's the best. Let's see where we're at. Talking about Wayne Dyer. Okay, here's a good one. So a clarifying question from Irene. So if the symptoms are caused only by hypoperfusion, is this still called POTS, or what could it be? So if you don't meet the POTS criteria, but we have cerebral blood flow that is hypoperfusing, then we call it OCHOS, which is orthostatic cerebral hypoperfusion syndrome. And that comes from Peter Novak. And I think it's a very, very useful way to think about it. So in this case, if you don't meet the POTS criteria, then that's what they would say you have. Cool. No matter over normal, got a little question here. Why does breathing out too much carbon dioxide signal for lower oxygen to the brain? Does it simply mean there wasn't enough oxygen to make ample CO2 to exhale to begin with? Great question. So the way that our brain is using that CO2 is actually like isolated to the vasculature. And it's usually the smaller vessels actually. And what its job, it doesn't have the ability to like see the big picture. All it sees is what happens within its own little space in the artery. So if we breathe out too much, its only job, its only sensor, it's like a cheap Chinese circuit breaker, right? So its only thing, it's like good at one thing. And its one thing is it's going to read how much CO2 is dissolved in the blood in its space. And when it's doing that, it doesn't know why. And because of that, when we're breathing it out too much, it can't know on the front end if it's because there was lower oxygen to start with or not. Our brain also uses the pressure relationship of autoregulation in the same artery as the primary ones. There's kind of a hierarchy. So the first thing that could cause the vessel to dilate or constrict is going to be the blood pressure in that vessel. And if that is stable, if that's held in its dynamic range, then we also get to fine tune it with the CO2 responses. That's assuming everything's working right. Now, in cases where it doesn't, we start to see interesting things, as you know. We can see interesting things where the reflexes and the way they tune to each other can either become decoupled, they don't work toward each other. They can be dysregulated, so they don't actually sync up. They can go out of phase, as you can imagine. But does it mean that there wasn't enough oxygen to make the CO2 to begin with? Not necessarily, but we can look at this. So when we look at the EtCO2 values, we're also looking at the SpO2 values. And in most of the cases we see, and I think you saw, that SpO2 levels are usually pretty great. So the amount of oxygen dissolved in the blood is actually usually pretty normal, despite having a lower CO2 signal. So if the oxygen level is lower as well, then we would say on the front end, the inputs aren't enough from the SpO2 reading, and that could happen. Now, that's harder to measure on a region by region basis. This is where like tools like FNIRS can do that, can look at that output. You can overlay them. That's a little harder to do. But then we also can look at the energy demand within the system and look at if the reflexes are normal. So what I mean by that, I'll give you an example. So this would be better to demonstrate, but I don't know if I have the way to demonstrate it at the moment. Okay, so we want to pair and couple and make sure that the autoregulatory curve and the CO2 are matching, first of all. If they don't match, then that's already a problem. And a lot of people will, especially in our post-viral world that a lot of people find themselves in right now, um, all of these reflexes are happening in the blood vessel. So if you think about the blood vessel, we have an epithelium, a mesothelium, and endothelium. And then a lot of you will go, oh, I know that word. And when we think about the endothelium, we want to think about the muscular layer inside of the blood vessel. And the dysfunction that may be associated with that may be that it doesn't accurately contract given the normal reflexes of either autoregulation, so pressure, or vasoreactivity, CO2. And they may not couple together well. Ideally, if I'm someone that has, let me see if I can, let's draw. Pull up another slide. Sorry, I'm going to spend a little time on this one because it's a good question. Okay, so if I have someone who has low cerebral blood flow, what we're saying is we don't know if it's because it's getting blocked coming in. We don't know if it's because the autoregulation's off. We don't know because it's neurovascular coupling or it's vasoreactivity. But vasoreactivity and autoregulation should go together, right? We said there's a hierarchy. So number one is autoregulation. Number two is going to be vasoreactivity. This is CO2. This is cerebral blood pressure, right? So think about this. Let's say that the cerebral blood flow velocity is decreased. If it's decreased, what should happen in the vessel? If it's decreased, we would hope that the vessel would try to constrict try to dilate in the brain to be able to allow more blood to come through. So that allows the heart to operate as a pump and try to pump more blood back up into the brain. Okay, so if the cerebral blood flow is down, then we hope that the blood vessel in the brain gets bigger, lets more blood in. Okay. In order for that to happen, we've also got the CO2 component. If I've got normal CO2, the higher that CO2 starts to go, the more it should dilate that vessel as well. So if I've got high CO2, then those two things go together, right? This is exercise, basically. So if I'm exercising, I want to be able to accept pressure so I can circulate quickly. And I want to be, if my CO2 levels are going up, I'm going to dilate to keep flushing through my brain. This is a lot of why we talk about exercise being so useful once you start to get into the elderly, because it maximizes the circulation through the system. It activates the reflexes of vascular control and helps us to be able to circulate blood better. Like, this is kind of some of the nuts and bolts underneath that. But now, well, this isn't typically what we see happen. In most cases, what we actually see is as the cerebral blood flow goes down, what would I do? Sorry. As the cerebral blood flow goes down, the CO2 levels go down as well, writ large. Like, this is from my experience purely. So we see this in a large, like in the highest percentage of the cases, we see the cerebral blood flow goes down, CO2 tends to go down as well. And this can be independent of the breathing rate. Sometimes it's because we're breathing wild. A lot of times it is not. So if that's true, on the autoregulatory side, we should be getting a dilation. But as this CO2 is going down, it's going to create vasoconstriction. So you can see where if the main job is to try to keep blood in your noggin, that CO2 is going to bugger it up, right? So it's going to make it so that that CO2 level is going to try to compete with the autoregulation component. So because there's a hierarchy, the autoregulation will come down and inhibit, or it'll desensitize the CO2 reflex. Okay, I know we just went in, I feel like I just went into class on you. I apologize. You guys didn't sign up for a neurology course. That's my fault. But the take home of this is that when we're seeing the cerebral blood flow drop, we become really, really attentive to what's happening with that CO2 to help us differentiate if we're trying to solve an autoregulatory problem or a vasoreactivity problem. In this case, what no N over normal is asking is like, well, those are all the back end, right? So you got this mitochondria, right? And we're measuring the back end, which is producing CO2. What about the front end of the oxygen going in? Well, the way we're looking at the front end, we have to look at it on a more global scale as well. And this is where we're going to measure the SpO2. And then we're going to look and see, is this CO2 a function of orthostasis? Okay, so everybody perk back up. High five. Pay attention to this part. Okay, eyes wide open. Do this thing with your eyes where you open them really big, and maybe it'll make you focus really good. Sorry for me, I'm having POTS people try to focus. I understand the irony here. So, but if this CO2, your CO2 levels from the mitochondria shouldn't, in your brain, shouldn't be drastically affected one way or the other if you're standing up versus laying down. That input should be minuscule in terms of what it creates in activity in the mitochondria. So if we're seeing orthostasis being the main driver behind the CO2 levels dropping, then we would say, are we really seeing that the mitochondria are shutting off by standing up? That doesn't make any sense. If anything, they should be a little bit more active and produce more. So if the CO2 is going down, we don't think of it typically as a function of shutting down energy production. And then we correlate that by looking at the oxygen on the front end. If the oxygen on the front end is just bombing, then there's nothing to make stuff out of. And then we might just see that mitochondria is fine. It's just not getting any of the imports coming in. And then therefore there's no output going out. Okay. So anyway, I took a long road to answering that question, but I wanted you guys to understand all of the little nuance behind it for understanding how the blood pressure and the CO2 interface with each other. And that tapping that you hear is me just trying to delete all this stuff so I can draw again. When you do this in Keynote, you can't just use the eraser, you got to backspace. Okay, so hopefully that's at least a little bit useful. Nicholas got some really good insight for you guys, and this goes back to the question we talked about a couple minutes ago. He said he was quite nervous during his tilt, which may have affected the results a bit. Do you feel like it's still possible to pinpoint the root cause despite this? This points to what we just talked about with the last, well, 2 questions ago from Catherine, when Catherine was asking kind of this same thing, right, in a different way. So that anxiety, we can pull that apart, but then we can kind of do a look through based on how those things are affected by orthostasis or not. So really good question. And it's really important because almost to a person, remember, most people are flying or taking a really long car ride to come and see us. They've already been to a ton of places, mostly places that have given them some measure of hope and then also taken it away. Most of you know what that feels like. Sometimes it's like being in love, where it's like you get burned enough times and you're like, I don't want to do that anymore. And like, I'd rather just be lonely and sad, by myself rather than be in a relationship again. Right. So like, I'd rather than get my hopes up about another treatment not working, sometimes I'll just back away. So most people are having these feelings and then they've chosen to do it anyway, which tells you about the people that come and see us. They're usually amazing people, super brave, super outgoing, and like just trying to do their best. Okay. So where'd I go? Oh, stop sharing. There we go. So that's the people that come and see us. So if you're already nervous, almost everyone is, and we account for that for everyone. So don't. Nicholas notwithstanding, this is a good question, and I know exactly where he's coming from, but I think a lot of people out there are probably shaking their head like, yeah, I would feel this way too. And so we know that coming in, we know that that's the situation people are in. We know there's a lot riding on it. We know you're nervous about being here. We know this feels like this is it. We got to figure this thing out. So most people will have some element of that, and you can see it in the takeoff. I'll maybe one of these days I'll do a longer one where I kind of show you what that looks like and how we look through, like, okay, there's the anxiety part. Now let's push in and look at the orthostatic part compared to the Valsalva part, compared to the deep breathing. And then we can say, like, is this something where they're just ramped up, or is this something where the reflexes are changing? Cool. Yeah, that's a really good question. I think everybody would want to know that. Thank you for asking it for everybody else. It's me, cervical instability and vestibular issues. I think it's a lot of people. How often do I find trauma or emotional issues are connected to POTS? Like I said, I'd look at it differently. So you may have a basic definition of POTS that puts you in that. I think, honestly, my honest opinion, here it comes. I think in a lot of people, there is an underlying physiology that just is from whatever happened. Usually it's something physiological. When we think about the sensation or the feeling or the emotion that comes with that, sometimes it can be really hard because our body is alerting us that something is going wrong. Something's wrong. I had this conversation with someone today, right? So someone today comes in, we've got this extreme hypoperfusion, but then also a vestibular problem underneath it where we got nystagmus, dizziness, we're drifting when we're walking. And so that becomes part of the question, right? Is like, how does all this stuff relate? And what we talked about is those things that are underlying it have been there for years, people looking at them, just not seeing it. But it gives you this underlying sense of anxiety. I feel anxious. I feel panicky. And then we start to look up and say, I'm feeling panicky. Why do I feel panicky? And the easiest thing typically to point to is either like I ate something that makes me feel bad, or I'm having a feeling that makes me feel bad. We tie anxiety to emotion a lot. Right? So, like, what happened to me that is making me feel anxious? And that's kind of like the parlance or the conversation that happens in the cultural community, is that there must be something that happened to you. And if you think about it long enough, you can think about anything that could have happened to you, and we can attach those things together. And sometimes thinking about them and having some self talk and regulating yourself can have that ancillary effect. So, there are people, and we've talked to them and we work with them all the time, where that inability to be able to pull it back in, so like basically the brain is overriding and running away with the attentional system, and that's what you're experiencing, and somehow being able to pull that back in is very necessary. We can measure that. But I think a lot of people also um, attach a meaning to an event that may actually be attached to a physiology. And these are cases where you'll probably see doing things that are more, um, dealing with emotional trauma rather than physical trauma, where it may take a bite or it may give you some tools that slow it down, but may not get in front of the whole thing. So I think those tools are very useful. And I think that the risk on using them is wildly low. We send people to use them all the time. We had a conversation with Dr. Sovi about utilizing some of those tools in his experience with DNRS. So I'm not saying this as a person who is like poo-pooing those programs, but I also think that it's useful to understand if to rule out there being something physiologically under it, because I've also had the experience where a lot of people spend a lot of time doing that, only to then find out that we have a vestibular injury underneath, or we have a neck injury underneath, when it would have been really nice to just solve that on the front end. So I think both things can be true. And I think using diagnostic tools can help you understand what's what in a way that becomes real very quickly. So good question. Corey's got 1 out of 2, 2 out of 2. Okay, here we go. Corey, non-directly POTS related. Got to chat with Dr. Marsico earlier. Loved it. Sent her a reel that I made to start my social media takeover. She said you may have gotten a peek. Wanted to see if you were cool with me posting it since it shows the clinic and you make a brief appearance in it. I did get to see it. I saw it this afternoon. I will say 2 things about it. First thing was, number 1, I love seeing you ride your motorcycle. Number two, well, I'm going to give you three things. Number two, it gave me goosebumps. Number three, I watched it while I was walking home from the office today. I had to stop to watch it. I realized I stopped watching it standing in the railroad tracks and immediately had to like jump out of the railroad tracks. No train coming, no danger, but like that's how enraptured I became in it. And then it made my eyes tear. So I would be happy to help you whenever you want. Post it, go nuts. We all support you like crazy. And we think the world of you and wish you the best. So thanks for doing that. Cool. Everybody go, Corey, if you want, go ahead and throw your, I think you're gonna put it on Instagram. Put it in here so people can see it. Put your thing on, get you some followers. You guys go take a look at it. If Corey does a good job, follow him. Yeah, it's a good story. I think a lot of people will connect to that. Thanks for sharing it. All right, so 9:36. I probably am gonna like once we get through the questions that we have. Bill, I think is the last one here. Then I will probably cut it. I was out too late last week, and while it makes it, I have a lot of fun being here. I also was a little tired on Friday, so I got to make sure we kind of close her down by about 10. Okay. Where are we? There we go. Okay. We've got. Let me see how. RSAJJPAL. I'm sorry, I don't know how to say your name, but thank you for being here. Appreciate you. So this is number two-parter. Would you expect an electrocardiogram to go haywire if a POTS patient exerts themselves, i.e. loading the dishwasher, while their symptoms are flaring? I find that my Apple Watch ECG looks super spiky and noisy for a few minutes after exertion on days when I'm feeling POTSy. So two parts to that. I think that's a good technical question. So number one is you want to make sure that we solve the technical problem. So is the Apple Watch tight? Is it getting a good reading? If it looks spiky, it may be because the reading is off. Then number two, sometimes when your heart starts to beat faster, it becomes you're reading just one lead, so it becomes more noisy because there's more spike train going through, so the electrical signal is quicker and it can accelerate that. So we'll see sometimes where it'll like double the beat. So somebody might have a heart rate of 80, and I know that's probably not where you're at, but it'll read it at 160 because it'll like count them twice. So you just want to make sure that the signal is clean and clear. And sometimes it's helpful to just like use a pulse ox real quick and correlate and make sure they're giving you the same info. Now, assuming that the technical features are fine and you're getting the right data, then when you say going haywire, when you exert, then it may mean that you are getting those like spikes, especially you talk about loading the dishwasher, moving up and down, which are going to cause like a bolus of blood to enter the heart and then quickly leave it. So it's like adding a lot of blood and then get rid of it all at one time. So we get these big oscillatory moments. So depending on how big of a wavelength you're looking at, you may be looking at those oscillations. And the other thing to consider is that just through the movement, if it's loose on your wrist, then we might be having technical features with it. You kind of want to notice also like what are your other experiences that you have? Like, are you short of breath? Do you get dizzy? And is it specific to different types of movement? So is it specific to just getting your heart rate up? Or is it when you're doing a lot of movement, you're moving your head around a lot, you're up and down a lot? Those things can also cause that turbulence in the blood flow that makes it more dynamic. Really good question. Good thing to dig into. I need a little bit more data though. Back to the AAG, the autonomic ganglionopathies. Is it related to Sjogren's? It's related to everything that has an autonomic ganglion. So the whole entirety of the autonomic system, everything all goes down. If you notice that only pieces of it are going down, either those ganglion aren't affected or it's not the autoimmune ganglionopathy. But usually sympathetic, parasympathetic, everything is depressed and not doing well. Marcy asks, I have EDS, strongly suspect CCI. So we're talking about, um, sorry, I'm reading something else. Craniocervical instability. Can you talk about how you diagnose it? Any magic words that we get insurance to approve an upright or open MRI? Is diagnosed at Stanford. They love to do that. I don't have any magic words. I'm sorry. But to talk about how to diagnose it, we did a live stream 2 weeks ago. It was another two-parter where I went through, I think you were there, maybe not, but I went through the criteria for that, how we look at diagnosing it, both from a bedside perspective. So like the orthopedic tests that you can do to feel if there is instability, and then also the advanced imaging. In the imaging department, there are groups that'll do just a flexion and extension CT, and those can be really useful. And then you can get digital motion X-rays are very useful as far as being able to see the stability level of those ligaments. And then also if those ligaments, when you're moving, the muscles aren't able to control control the positioning well enough to support to where you start to hang on the ligaments and they go further than you should. And then you want to note, are you symptomatic in those positions specifically? There's a lot we talk about that might be worth another watch, because I think we spent like 4 hours in that realm, and that might be useful for you. Cool. If you didn't see it already, you might have seen it already. And if so, maybe I'm not answering your question very well. Bella says good night. I hope she was able to see the answer that I gave her. I don't know if she logged off. Positive space. Can you treat someone slowly if close to the clinic? I don't know. I don't know for sure what that means. I like to treat people quickly, as I'm guessing you know, which is why you asked the question. That is a good question. I don't know what's wrong. I have to know what's wrong to know how to best approach it. But anytime we're looking at treatment, it's within metabolic capacity. So it doesn't do any benefit to push somebody past what they can do. I talk about this a lot as being the equivalent of putting someone on a bench press. If they're capable of lifting 100 pounds and they want to lift 300 pounds, we can't just say, like, that could be like, well, I'm capable of laying down and not being dizzy, and I want to be capable of running and not being dizzy, right? That would be an equivalent. We don't just start people out running, or we don't just start them out standing up, playing pickleball or something. We start with what they're capable of doing and slowly, incrementally build them up. Same way, if I was on a bench press, I wouldn't start and just put 300 pounds on and say, good luck, and let you drop it on yourself and hope that one day eventually you like magically could pick it up. We would start with 100 pounds, and then 102.5 pounds, and then 105 pounds, and then 107.5 pounds. And we would work up gradually until we're able to get some momentum and be able to get function back. So when we talk about fast or slow, that talks about it in terms of like time on a calendar. I think what I think is a more useful way to look at it is, how can we dose it appropriately so that every day you're using the right amount of energy to build it, rather than trying to execute things that ultimately end up stealing energy from you and don't allow you to be able to gain traction. So the way we organize things is for that, is to be able to focus the amount of energy you're using to conserve it and focus it just on increasing that curve of capacity. Lavender Lemonade says, thank you very much. We got a response to Catherine. Thanks for sharing. How long did retraining take? Was the hardest part? Any thoughts on low dose naltrexone? It's a steroid. You're just doing the low dose steroid. So you're augmenting a system that allows you to do that, in hopes that by using that steroid, you're going to bump the system enough to just try to be able to heal and get you through it. For most people that have been doing something chronic, there's an underlying problem. Maybe using steroid for a period of time helps you get through it. Maybe it doesn't. You can try it out. I don't prescribe them, not a medical doctor. We don't have a license to do that. So it would depend on the underlying problem and if it makes sense for what someone's going on. We're in Garrett's classes, Economics of Immigration and Foundations of Information Systems. If anybody wants to go take some courses with Garrett, I'm sure he would love to co-teach that for you. Smart kid, wonderful kid, love that kid. Good luck, my friend. I think that the VNS and interoceptive training is an interesting topic, right on. And the VNS is vagus nerve stimulation. It's interesting. I think it's more popular than useful for a lot of people, but I think for some people it is very useful. Garrett says, thank you. I appreciate you, man. Dancing P, nice presentation. Catherine, happy to share experiences. Carlos, good question here. Welcome, Carlos. Can it be POTS? If I only have exaggerated response and heart rate spikes to light exertion, like walking around, can get my heart rate to be 140 after being at rest at 95 to 100, 105. Orthostatic spikes don't happen always. That's a really good insight. That's worth investigating, right? So it may not be specifically POTS, but we can obviously see that something's going on with this autonomic energy systems, right? So you were trying to activate and use more energy. We're having to crank the heart rate to try to compensate to get there, and it's not meeting the demand. The resting heart rate between 95 and 105 starts to look more like inappropriate sinus tachycardia if someone's experiencing that. So that's kind of like sending you down a different phenomenology road where we're looking at different outputs in the cardiovagal system. That starts to become kind of an interesting perspective there. So it may not be specific to POTS or that basic diagnosis of POTS that you're after, but starting to tease out those other autonomic components are there. So I wouldn't say like, oh, you're out, like tough luck. I'd say those are really good insights. Let's dig into those and figure out why your resting heart rate is so high to start with. Any brain injuries, any infections, car accidents, trauma, sports, that sort of thing. Start there. Then we look at like has been the conversation a bit tonight, looking at attention and arousal systems. Are we getting appropriate excitatory and inhibitory responses from that? Cool. Also, thing to note for the traumatic event components is the way that we inhibit that limbic output is through frontal limbic system. So we have to have an intact frontal system. So people that have brain injuries like self-talk is one way to think about that, but there are a lot of other ways that we also stimulate frontal outputs through eye movement, through cognitive control, through timing, through dual tasking. So those may be layers that become useful for you guys as well. Just a thing to think about. Thanks for the question, Carlos. That's a good one. Here we go. So my PASC doctor said that they see a lot of patients with incidents of low pulse pressure, which is the difference between systolic and diastolic numbers, high diastolic numbers. When they got worse, my blood pressure was 133 over 110, and it felt terrible. That's a good point. So here we're seeing that acceleration of blood pressure, which takes us out of those criteria. And just like you said, we're looking at like where's the congestion in that system. Very cool. Very cool. Oh, Elsa, you're supposed to be in bed. It's 2 a.m. typing on the phone. Not anxious or breathing changes and is reproduced every time, even when relaxed. Oh man, I forgot where we're at in that conversation. Let me see if I can get a reminder real quick. She was asking, is it still POTS as well? If the heart rate increases and the diastolic pressure also goes up. Yeah, not anxious or breathing is reproduced every time, even when relaxed. Yeah, this is where we start. So in scenarios like this, again, not medical advice, but this is where we would start looking at, okay, not anxious, we're not breathing differently. but blood pressure is starting to go up along with the heart rate. We want to look at frontoreticular output. So these are like in the functional components of your brain being able to generate the signal. And then also making sure we're not having something that is causing constriction of the vessels going from the head. As you know, it's like if you're using the hose to water the flowers and not enough water is coming out, you try to crank up the hose and get more water to come out. So if we're having the heart rate and the blood pressure going up both together, then something is signaling that we're not getting enough, and it's trying to close the feedback loop and continue to push blood, typically upwards toward the head. What is resisting that? Cool. Great questions. Where am I? Oh boy. Does having the MTHFR have anything to do with POTS? I mean, if methylating in the liver is causing your heart rate to go up, then that could be true. But I wouldn't say that that is a smoking gun for most people. Let's see. Leanne. Welcome, Leanne. She said, with transcranial US functioning tests with the cervical movements causing hypoperfusion, are there any available studies or norms with these movements? Are there studies with whiplash, EDS, etc.? So I will tell you what we use as our norms because they haven't been set relative to those. So there were studies that were done. So when they would do endarterectomies, an endarterectomy is basically like if you get plaques built up in the carotid arteries, then you start to get occlusion. Like once you start to get toward 90% occlusion, you see changes in carotid flow. What's crazy is you can kind of have normal flow with pretty gummed up arteries. But what they'll do is they'll go in and they basically like roto-root out the artery and try to clean out the inside so people can get blood flow again, right? So that's a surgery that people would do. And when they do that surgery, they kind of have to lay you with your head turned. But part of the problem with that is if you're anesthetized, as you guys know, like you're just a wet noodle. And if you're a wet noodle for a long period of time with your head cocked to the side, you can get compression of the carotid arteries. So they did a study and they wanted to see like, well, we don't want people stroking out when we're doing the test that prevents people from having strokes. So what they looked at was these seated head turns, and they were trying to correlate how much change people would have with a Doppler before it became problematic for them on the surgical table, right? So what they landed on was a 20% drop on head movement. So that's basically like 20% is the standard we use, because it's like if they won't put you under with your head turned because they're afraid of you having a stroke at 20 degrees, or at 20, excuse me, at a drop of 20%, then that in our mind, that qualifies as like, we at least want to beat those people, right? So if like the people that are at risk for the stroke when you knock them out, we at least want to beat them, because that's saying like, well, our people, like, what if they fall asleep like that, right? Or they're just like at dinner talking like that. Do we want those moments? So we use that as our cutoff because of that, that previous testing. But there isn't another group that has done a marker to try to understand what the normative data on that should be. We are using like the worst case data that was previously presented. So if you're looking to do some research, Corey can put you to work. He's in charge. Corey, I'm making you lead manager of all of the other tasks that we're doling out as well. Cool. What do you think of the approach of returning perfusion to tissues as an approach to improving vascular control? I think that's what I spend a lot of time doing. I think that's a good synthesis of it, is we want to work that vascular system so that it becomes adaptable to normal responses again. Marcy says the heat acclimation advice is helpful. Thank you. Thank you for giving me a moment to try to explain it. Eileen says we're doing 10 minutes of sun this week and then sticking the hands in the pool. Love it. Let us know how that goes. I would like to hear your experience with that. Can your brain attach the unsafe feeling to the repeated feeling of being starved with blood flow to a reflexogenic problem, and thus step of fixing it after treatment is brain retraining? Good question. So yeah, so the way we describe it is you start to get habits because we tag things that may or may not be relevant, but we can make them true. And what we typically, I don't like using this word because it makes it sound like we're poking at people. I'm not poking at anyone. That's a very important part. But we get habits around activities because we're trying to avoid stuff that we think is going to harm us. So then we have a habit and then we have an emotion to the habit. And what these are typically called, especially in cases like OCD, which is really important, is we start to get compulsivity, or we get stereotypies, or another way to put that is that we start to get superstitions, where we have a feeling, we look around, we assume that something is the culprit, so we stop doing that just in case. And then we vigilantly stop doing that thing to the point where we become very aware of it, right? So B.F. Skinner's pigeons are the primary picture that a lot of people use to describe this, which is he had these pigeons and he would feed them purely at random, no rhyme or reason. So you have these starving pigeons and you feed them every once in a while, but when they get hungry, they start doing stuff to try to get food. And it turns out whatever the stuff they did to try to get food was before you actually give them food, they'll start doing that thing over and over and over again because they think that's why they got the food. So if it's presented to us that the problem is probably from this, and we develop a habit around that, then we will start to act that way. One of the things that's really helpful is to build evidence. So like if you're afraid to stand up because it's reasonable, because your evidence has been, when I stand up, I feel like I'm going to pass out, I don't like it, then you're going to avoid it. But then if you start to get evidence that, ooh, I'm starting to be able to stand up, then you want to do the things that support creating evidence of that pattern. So I need to do things where I'm standing up more. And once I can do it more, I need to do it in more difficult circumstances so that I'm in my mind building evidence that I no longer need to worry about that thing and I can actually start to seek it out. In our we call this the like the slam dunk contest award, where they give you a score like 0 to 10. So your limbic system, its job, I mean, this is a very unscientific way to say it, but it's generally true. So your limbic system's job is to help your memory and your brain tag the important events of your life so that you can remember to either approach them like we want more of that, or like, hey, stay away from that, we don't like it, let's like be aware of not doing that again, right? So we have these approach and avoidance behaviors, super simplified. And the limbic system's job is to help us tag that so we remember the things that are bad or good, right? Approach or avoid. And we typically weight things even more so for the things to avoid, because those are the things that could, end your time on the planet. So basically every event of your life that is happening, you're constantly getting this score of how important it is. And you can think of it as kind of like a 0 to 10 scale, with 0 being we don't ever want to have that happen again, completely avoid it forever, and 10 being like that was the best thing I can ever think of, let's do that as much as we can in this lifetime. And then 5 is like neutral in the middle, it's kind of like just the pattern of our day, whatever, you don't have to like remember that with saliency, with vigor. So most of the things that happen in the day are like a 5 or like somewhere between a 4 and a 6, and that's fine. But the things that we should super remember, they get flagged with those higher numbers, they get tagged in our memory, they get bound together, and they're things that we tend to remember. Most people will notice that negative memories stick pretty hard. Positive memories also stick, but they stick in a different way. And so when we overlay this with an unknown illness, then we start to tag a lot of things to the illness because we don't know what it is. And it's safer for us to tag a lot of things to stay away from than it is to like take the risk of being exposed to those things and feeling worse. So generally speaking, we start to avoid way more things. And I'm not saying this as someone who's not done this. I've felt this way too. I know what this feels like. Okay. So I'm not like this isn't an accusatory statement, but that we all do it. But then we have to start, but once we know like those aren't the thing, then we have to start exposing back to them so that we can flag and get those fives again and start to move our average from like a 0 toward a 5 so that our limbic system isn't tagging that and freaking out all the time, saying like avoid that like crazy. And it starts to become more assimilated to it. This is the nature of exposure therapy, so that the things that we were maybe using as a habit of avoiding don't become like the thing that prevents us from moving forward. So a lot of time on that topic today. There's a lot of people that talk about that, but I think it's I'm giving like a point counterpoint to where it's useful and where it's helpful to dive into like some of the deeper physiology. Okay. Wildfire. Wildfire. I have a secondary MS. I'm assuming that's multiple sclerosis, and I've been diagnosed with orthostatic hypotension and dysautonomia. Did my MS cause this? I can't know for sure because I don't know anything about this case, but we do know that there's a probability changes in outputs from the brain can cause both hypotension and dysautonomia. So if that's where the overlap is, that's worth investigating because that could be true. Obviously, I can't give you advice on that without any more knowledge on the internet, but certainly plausible. Dancing P, good point. Symptoms were worse when iron was low. That helped, got better. Still having some symptoms. Okay, sorry. Dr. Genia sent me a message because she knows I'm supposed to go to bed. My symptoms were worse when my iron was low, and low after my infusion. I got better. That's good. So we went through that first step of the basic diagnosis, make sure it's not something else, and then we can focus on the other things. Really good point. Awesome. Okay, this one looks like it's one for the group, so I'm going to let the group do that from HH. Katie. Okay, I'm gonna do Katie's here. If you guys could do me a favor, because I've got way too many, but I've gotta head out. Oh man, you guys are awesome. I'm still scrolling. Okay, we are going. Wow. Wow, 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 wow. You guys are amazing. Okay. So what I'm gonna do is Dr. Genia made this thing for everybody. And you might have seen it in the chat here if you're on YouTube. If you've got other questions that I haven't gotten to, we set up a voicemail box. In that voicemail box, that way you guys can like say the question. Maybe you can give a little bit more detail. It may be easier, or if it's easier to write it, send us an email. But if you send them here and like give us your first name, there's this link. We're going to try this out. It's in the chat, so hopefully you guys can click it. But or I don't know how else. I think it's linked to other stuff in the socials. But if you send us a voicemail there, we can play it for everybody, and then I can answer it as well. Or you can send us an email and we can try to just tag it in. Next week, I'm going to do I think it looks like we're just going to do Q&A because we've had so many questions that I want to make sure I can get through them. So if I didn't get to yours tonight, I apologize. I want to be able to try to do that, but also, you guys just got a lot of questions, so I also have to go to bed. So I'm going to do that, and send me the notes, and we'll play them, and we'll make sure we connect with you guys. I want to make sure we get our questions answered. That's our goal, is to try to. Well, number one, our goal is actually to try to present some new concepts to give you some new context so that it helps you to be able to ask even better questions of the people that you're seeking out to help out. So thank you guys so much. I'm going to call it here. Maybe we can, if you guys have a question that's not answered, just send it. Dr. Genia, we're going to try to go to that website or to that voicemail box. If you can't do that, drop us a note in Instagram or on YouTube, send us a message, and Dr. Ginny collects those and we'll try to use them. We also try to use them to make our short videos for the ones that can help with that. So feel free to give us those questions as well that way. And if I don't get to it, come join us next week and I will try to get to it there. Leave us a question early and then we'll try to get it early in the line. Okay, so have a great night. Thank you guys so much for coming. And hopefully I see you next week. Keep working hard, keep fighting. We'll talk to you soon.